Okay.
Hi, Megan. I'm Rebecca Griffith. I'm the ED DPT, and welcome to our next episode of Admitted or Not, and another Feature Friday for you today. I am here with Dr. Megan Mitchell, one of my friends and fellow alum from the University of Colorado Physical Therapy Program. Megan, welcome. Go ahead and introduce yourself.
Hello, I'm Megan Mitchell, physical therapist. I've been practicing in level 1 trauma for almost 12 years. I have moved down from the floors to the trauma ICU and now am primarily in the emergency department, the adult emergency department. But I do like to cover over in the pediatric emergency department when they let me. And I have never felt more inadequate as a provider than when I went to the labor and delivery emergency department. I probably will not venture that far out consistently, but it's certainly an area that
sounds like a challenge.
It is, and I'm not good at it.
Okay, well, let's back up a second. Tell me about your emergency department, because it sounds like there's a lot of stuff going on there.
There's a whole lot. So we do adult and pediatric. So it's level 1 adult trauma hospital and a level 2 pediatric trauma hospital. So no pediatric burns. And then neurosurgical cases most of the time. So we do adult trauma, adult medicine, walk-in clinic, urgent care, a separate urgent care that we just moved out of the adult ED space, and then an observation unit that's all adult based. And then we have adult psychiatric emergency department, which you do get some patient consults in. Then pediatric trauma mostly, not that you can't get medicine patients, but pediatrics, and then labor and delivery is totally separate.
And you cover all of that, or do you have multiple PTs?
I like to cover all of that. It depends on how busy the day is. So if my caseload is jam-packed and I don't have more room to add patients, then somebody else will absolutely have to come down and join me, even if they are not as excited as I am about it. I would say I'm the primary therapist down there, but I'm not the only therapist down there.
And do you staff 7 days a week?
We staff the hospital 7 days a week, and the ED does get priority.
Great. Okay, so how do you, like, I don't have a lot of pediatric emergency experience. If a pediatric case comes to my emergency department, like, we try to figure out, can we send them somewhere else? Because we're just not like very well set up for that. I have had a run of pediatric cases lately. Like, what would you say to somebody who's trying to like manage the lifespan in the emergency department?
You mean manage the lifespan? Like,
yeah, so if you've got pediatrics all the way through geriatrics, like, and like labor and delivery, like that's the whole lifespan. Yeah. How do you manage to manage all of that?
Well, I prefer adults over kids, and I prefer kids over labor and delivery. So that's how I would triage myself. But I know that we don't have a lot of therapists who are even remotely interested in labor and delivery emergency. So I think I would by default be set into the labor and delivery emergency department over a pediatric. Some of our OTs who are pediatric specialists are more comfortable flexing down into the pediatric ED than our PTs are.
Interesting.
Yeah.
Now, I can imagine a pediatric emergency that would require physical therapy, but talk me through like a case example of a labor and delivery PT patient in an emergency.
So basically anybody who is past the second trimester or within the second trimester or the third trimester, if they have any acute medical injury or illness and they want to get urgent care, they'll go straight to our labor and delivery specific emergency department, not to adult urgent care and not to the regular ER, because they have the the complexity of having the fetus as well that they need to be able
Yeah.
to manage and make sure that they're not getting medication interactions or, treatments that are contraindicated for pregnancy. So they are automatically sent to that specific care area.
So are you primarily seeing those patients for musculoskeletal issues?
Yes.
Excellent.
A
Okay.
lot of SI pain, a lot of low back pain, a lot of pelvic pain,
Yeah.
gait troubles.
Okay. We see a lot of those patients too, just they're on the floor and not usually in the emergency department. So
Yeah.
maybe that's how that's different, but that's crazy. So you've got a lot on your plate.
Yeah.
And I love that you're like a really passionate, involved ED PT, but I want to talk to you a little bit about emergency physical therapist practice as a whole, because it's not just what's in the emergency department, right? Like it's everything. It's disaster, wilderness, sideline, like combat PT. There's so much to being an emergency physical therapist that the way I think of it is it's not really by your practice setting, but like how you manage patients. And I know you have a special niche practice area that I don't think many people know about.
So I am pushing PT in our facility into disaster response and emergency management. So I've kind of taken on this space of if a disaster happens in our community and people are coming to the hospital for care, who is a part of the first receivers that take on those patient care? So at this point, what traditionally happens is that the use of the therapy department will be to decompress the hospital, empty out the beds, discharge people as safe as you can to make room for those who are coming in with urgent or more urgent needs. And that's totally fine.
I mean, yeah, it seems like it makes sense to me. Like that's a good role.
But when that role is done, at least at my facility, we were then relegated to transport. So rolling patient from A to B. Again, totally fine.
Mm-hmm.
That's not the best use of our skill set or us as a finite resource. So
Sure.
our executive staff who have, no place in the emergency department can fold sheets and roll patient from A to B. Like that is what they can be useful for, because they're not going to be running the minutia of a hospital in that moment.
Right.
Okay.
All hands, and you're talking like an all hands on deck,
all hands
catastrophic scenario.
Yep.
So I think most PTs, Megan, would probably pause you right here and be like, hey, if there's an all hands on deck catastrophic scenario, like I don't want to be part of that because I went to school to become a physical therapist. I've got my banker's hours. I don't want to handle fluids. I don't want to handle really sick people. I don't want to handle anything dangerous. So why are you saying that we should be part of this?
Well, you already are. It's your community. It's happening anyway. It doesn't matter if it's happening at the hospital. We've had plenty of catastrophic events happen in school settings. So school shootings tend to be a big one.
Yeah.
But a couple of years ago, an airline dumped jet fuel on a preschool or an elementary school, and the entire kindergarten class was covered in chemical contaminant that was jet fuel. So it doesn't matter where you're practicing at. This is there, and this is your neighbor you're taking care of.
Well, I can think of two examples. I have a friend who works in the school setting, and she recently had to shelter in place in a closet with kids during an active shooter incident. And then I live close to the STEM school in Highlands Ranch, where there was a school shooting incident a few years ago. And very close to that school was a private practice PT clinic. And that clinic owner opened his clinic for people fleeing to shelter and take cover throughout that whole event.
Mm-hmm.
And they didn't know where the assailant was, but he really like stepped up into that role to help protect his community. So I get what you're saying. But also one of my favorite Megan Mitchell quotes, which I steal from you often and liberally, is there's no such thing as a physical therapy emergency, but there should be physical therapists in emergencies.
Yeah. You know how to respond to this stuff. It's not new. It's not a different skill set. It's a different application of the things you already know. Can you take someone's vital signs to determine if they are in fact alive or dead? Of course you can.
Check.
Can you open an airway and provide rescue breathing?
Check.
Yeah. Can you do CPR?
Check.
Hopefully, because you better be testing on it every 2 years to keep your licensure.
Well, and I think just those things that you've mentioned, like if I'm standing there and I'm not doing those things, am I liable for not living up to my full licensure scope in that situation?
Short answer I'm going to say is no,
Interesting.
unless you identify yourself as a skilled provider
Mm,
or you are functioning in your professional capacity.
interesting.
So if I am on the job and I am by my employment required to respond, then yes, I need to provide
Need to
CPR
get
and
it done.
appropriate care.
Yeah.
If I happen upon somebody who fell in the middle of the street and I haven't identified myself and I'm not comfortable going into that scene, then I'm not legally obligated. Does that make sense?
It does.
Yeah.
Ethically, maybe a different story.
Yeah, get into ethics and morals, it gets a little bit squirrely, but it depends on the role that you happen to be functioning in that moment.
Interesting. Okay. So beyond that, beyond our CPR, our rescue breathing, and vitals checking, what can I do?
Do you know how to splint somebody so they don't have more pain or injury when they move?
Yeah, I mean, we do that all the time in acute care, right? Like, how do I get
Absolutely.
you with this sternal incision up and moving?
Absolutely. Can you do a head to toe assessment to identify injuries?
Yeah, I mean, I do that at work, and I would hope as direct access providers that we would be comfortable with that.
Absolutely.
Mm.
And you get to work on your differential diagnosis, which is probably my
Yeah,
favorite part of what we do.
yeah, that's the fun
So
part.
right there, and then add on how do you move somebody with an injury without causing more damage? Of course we
Mhm.
know how to do that. Like we spent our entire professional training programs learning how to move people with injuries. So that is field work. You have identified a patient, you've intervened where appropriate, and now you are facilitating rescue.
I think that's amazing. I never thought about it that way. I also think like PTs have a good spidey sense
Mhm.
of when something's real bad.
Yep.
Like we know what bad looks like, we know what like kind of bad looks like, we know like what we can fix, and then we know like what is a huge problem that requires somebody else's help.
Yeah.
Which
And
maybe a patient transporter might not have that same experience. Maybe somebody who normally works in the cafeteria would not. So I can see what you mean about us being a skilled but finite resource.
yeah. Now let's add on a complication. So specifically, one of the areas in my hospital that I switched or that I was active in changing was that response piece. So once we've decompressed the hospital, those PTs who are comfortable functioning in the ED can be assigned as primary care providers in a medical operation or a mass casualty event. So we would be staffed in the ED as a provider,
That's great. Because we
which
are, right?
I actually pulled from our international literature. So if you, without diving too far into patient triage and mass casualty triage, if they are walking wounded or delayed, so green or yellow tagged, those are folks who are not going to have eyes on at all times.
Yeah.
You, with your very skilled eyes, can look at somebody, make a medical assessment like, is there a change in status here that makes them a higher priority? And you can keep an eye on those folks while your physicians and your nurses are managing the critical care patients.
So I had an experience like that during this last COVID surge in Colorado. We were on crisis standards of care. We had like our waiting rooms were overrun with people. Our hallways were full of patients waiting to be seen. The ambulances were dropping patients off in the waiting room.
Mhm.
And I was taking a shift at night, like not as a physical therapist, but really like you're always a physical therapist. But my job is to just be helping hands and do whatever I could do within my scope.
Yep.
And so the role that I took is kind of what you're talking about. Like those patients that were in the waiting room, first I helped the ambulance transporters get the patients off the gurneys and into a safe place.
Sure.
I took vitals on every patient. Like I would start at the beginning of the hallway that was double lined all the way down. And I would just start and go all the way down and come all the way back up. And I'd get vomit bags and blankets and like whatever was needed, right? Some
Yeah.
patients, I had to find oxygen for them because when I came back around, their oxygen sats were 80 instead of 90. But still,
Mhm.
there, you know, and some patients were waiting eight hours to see a provider. And I did do some of that triage. Like the last time I checked on you, your temperature was 103. Now it's 105. Your blood pressure 70/30. Your tachycardic and your oxygen level is going down. And your alertness has declined significantly. Like I'm going to move you to the front of the line. You
Exactly.
know, the person who keeps walking up to me and saying, hey, like I've been waiting for a super long time. Do you think maybe you could get me another glass of water? Like I'm less concerned about them because of how well they're moving, how well they're communicating, they're making their needs known. So in that
Exactly.
case, I guess I really was like helping with triage.
Yep. That's exactly what you would do.
Interesting. I love it. Okay. But maybe it would be like a little bit different of a scenario
For
for like a mass casualty event. Do you feel like, because this kind of felt like a crisis for sure. Do you think we're just all used to it by this point? Or do you feel like there would be like more panic and more drama? Like that's what I'm worried about. Like, can we like function and know what we need to do in that like moment of scariness?
I think those who are well trained and drill in this, it
Yeah.
becomes so automatic that you don't have to stop and refresh and actively think about it because you
Mm,
know what's happening, you know where your resources are, and you know exactly how to manage it. But learning in the moment, I mean, in the ED literature, if you are not trained to function in the ED, it is
mhm.
better for you to not even be in the ED or around the ED because
Fascinating.
you are a liability. You don't know what you're doing, you don't know the process, and you don't know where stuff is.
So all these EDPTs that are hopefully listening and watching to this,
Mhm.
that are like, wow, that could be me. How do they even begin training for this? Because this is not something that I learned in PT school.
I know, me neither. So there are a couple of ways I went about this. There is FEMA classes online, and I would say start with FEMA ICS 100 and 700.
Okay.
And then your emergency management teams will have additional training opportunities that were required to participate in per various regulations through OSHA and Joint Commission and CMS and all that stuff. So really getting in there and learning it first and then start participating in the active drills.
Okay. So that's definitely an opportunity that's available. But my understanding, based on our time together, is that you go a little bit above and beyond this.
Well, that's because I'm a control freak.
And
Um,
you're out in the field a little bit as well, not just waiting for the emergency to come to you. Can you speak to like your experience out in the wild?
in wilderness or in chemical weapons. So we can do both.
Well, obviously all of it, because absolutely everybody wants to know. Now that you've said that, now that you've said in the wilderness or with mass weapons, like people are like, what? So now I think you gotta spill the tea.
I'm getting the sense that you did not take a bioterrorism chemical weapons elective in school.
I mean, I didn't. Um, I did not. I think my elective was like on
Soft tissue.
animal physical therapy or like manipulate advanced joint manipulations. And nobody ever said, hey, like let's stop biochemical weapons of mass destruction.
Yeah. So we'll stick with the hospital emergency response for right now.
Okay.
So the emergency regulations for hospitals, they require that you plan for all hazards. So chemical exposures, biologic exposures, radiologic exposures, explosive events, like all of that happens naturally in our society, whether that is something super benign, like an oxygen tank gets stirred up in somebody's trunk and blows up, or I don't know if you remember this, but when marijuana was legalized and everybody was trying to extract the oils and they were blowing up the house with all the butane.
Yeah, I've seen quite a few meth lab incidents actually.
Definitely meth lab incidents. And then like chemical exposures like gasoline covering your patient, or in the case of that elementary school, it was the jet fuel that was covering a whole
Yeah.
classroom full of people. And then biologics, so like foodborne illnesses. And I don't know if you remember this case, but the food shelter, the rescue mission had not cooked their turkey properly.
Oh,
And like 60 to 90 people came in at once, expelling from both ends of themselves because everybody had food poisoning.
oh, that's not good.
I know, right? It's actually, there will never be enough resources for that in any department ever. But coming out of both sides of them.
That's a
So just
shitty
kind of
situation right there.
quite literally. So the things that are sort of in our environment anyway, but
Yeah.
then you add on the complexities of national security and hospital preparedness programming, which is part of the federal requirement for emergency departments. So
Mhm.
we plan for these things in the context of a terroristic event. So take your Las Vegas shooter situation.
Yeah.
Not necessarily intended as a political terror event, but certainly caused fear, right?
Right.
We had mass casualty, terroristic event in a space where everybody was coming at once. There's no way around it. You have to be able
No.
to pull your resources.
Yeah. And I've also heard you say like the best time to plan for an emergency is not during the emergency.
Oh, absolutely not. But there is just-in-time training. It's called just-in-time training. That is not where you want to be at if you were going to function primarily in the ER.
Okay.
But I do like this stuff. So as part of the emergency management team, they sent me down to Alabama where we got to practice the response with chemical weapons.
What?
I know. I have this cute little pin on my lanyard. It's a snake, but everybody thinks it's an IUD, and I'm just, supporting the goalie, so to speak.
What? That is a random thing for people to think. But I bet it's a good conversation starter.
It's a very good conversation starter.
So
But I do want to say though, the training itself is free, and you will never find a week-long PT Con Ed course that is fully covered and free.
and then if you do that free training, does that obligate you to anything? Are you then
Um,
required to respond?
No. So it's still volunteer based at our hospital. I choose to respond because I really like this stuff.
Yeah.
If you're going to be in the training, you're not going to want to pull the resources of that training away from somebody who is actually wanting to respond. So
Yeah.
you don't want to, like, that's legitimately not what you want to do.
Don't do it.
I mean, don't waste your time.
So outside of the hospital response to these events, tell me a little bit about the stuff that you do in disaster response around the world.
So I really like disasters. I like the chaos in the disaster.
You're the hot
So
mess express.
I know, right? I am a hot mess, and I like to be a part of the hot mess. So in Colorado in particular, we're very prone to wildfire.
Yeah.
So I partner with a volunteer organization called Team Rubicon, and in the state of Colorado, we respond to, or we function on the full spectrum of disaster cycles. So in the mitigation, preparation, response, and recovery. So we function with a lot of wildfire operations.
Mm,
It can be anything from home ignition zone assessment, cutting down trees and underbrush so that you don't have these large areas that can create chimneys
yeah.
for burning. I spent a couple of weekends last summer cutting down trees after the wildfire that went through Rocky Mountain National Park. I'd love to
Yeah.
name them, but there's so many of them at this point, I can't
Right.
remember. But you're covered in soot and you're learning how to use a chainsaw, and you have to have your field evaluation skills on alert, because you can have anything from a chainsaw strike that requires a tourniquet application to twisting your ankle on a rock because you're on a steep slope,
Or
burn, or having a log fall and hit you in the head. And
smoke
now you have
inhalation, I would guess, maybe.
So the smoke stuff gets into a different part of it that we haven't gone to yet. So at this point, I do a lot more mitigation and recovery.
Okay.
Response gets a little bit different. So right now we're, I say we, but some of our colleagues in physical therapy are working on getting PT as a qualified fire camp responder
Ooh.
for the Forest Service and for these hotshot teams. And at some point we'll transition, hopefully from medical fire camp onto the hotshot teams
Interesting.
as an embedded PT,
As an
more like the
embedded
military
PT.
model.
Like fire combat PT.
Mhm.
I love that. Okay. So are they borrowing from the military model for that?
I don't know, because we're still in the works on getting PT approved for the fire camps. And that hasn't come through yet, but Department of Interior is working on it with our colleagues in the sports section.
Oh, shout out to the sports section. There are
Yeah.
also emergency PTs, right? Like our sideline PTs, those are definite first responders.
Yep.
And then when I get those patients after they've come off the field, I'm the first receiver. Yeah. Is that what we call that?
Yep.
Love it. So on the like federal level, are PTs being included in disaster response?
Not outside of the VA. So the VA allows for PTs to be a part of their teams. So
Yeah.
they have like response teams. Outside of that system, no, we're not recognized at all.
And it seems to me like you might be doing some work to change that.
I haven't figured out who the right person to talk to is, but what I'd love to do is change our national disaster medical system to recognize PT as an approved provider so that we can at least compete for some of those jobs
Yes.
on the disaster response teams.
Okay, I love it. So I'm going to guess that people listening are like, this is the coolest thing I've ever heard. Are you going to share some information with us on how, like, best steps for people who want to like learn more and maybe get involved in some of this?
So I would love to have a roadmap. I really would.
Yeah.
I've been kind of making this up as I go along because
Love
it did not exist.
Just like an emergency PT.
Right. The short answer is that this does not exist for PTs in this country.
Okay.
If I were in the United Kingdom or in Australia or Israel, not a problem. They're already well embedded into their national teams. For me, the access points that I needed was the emergency management team at the hospital system. And then I needed a volunteer organization at the state level where I could just train. I could learn stuff. I can train on the process. So I went, so hospital emergency management, that's its own thing. Your state, every state should have a volunteer organization list. So you sign up, you take your ICS 100 and 700, and then you say, I want to participate in this kind of thing. So if search and rescue is your thing, then you sign up with your search and rescue team, and then you start to train with them. if you are a mountaineer or a cave diver and that's your thing, you would sign up with those rescue teams and train with them. For me, I signed up with CERT initially, so the Community Emergency Response Team, again, just to learn the process and start using the language of incident command. And then I started to step up in Team Rurukon in functioning in those roles as well. But they are running, your states are running drills all the time because they have to test the process. It's not only a good thing to do, but it's a federal requirement that they are practicing their drills.
Love that. Okay, so we'll include some links on the blog about how to look into some of these organizations, find the classes that you're talking about, and just places where people can learn more. Does that sound like a plan?
Absolutely.
Okay, so my last question for you on admitted or not is tell me about a case in either in the emergency department or as part of your disaster work. And I want to work through it with you.
Okay, so the case that got me the most excited to function in the emergency department. 20-year-old female came in with gait difficulty. And we were consulted for foot drop. So what would you like to know about this patient?
20-year-old consulted for foot drop. When did it start?
New onset, last 24 hours.
What was she doing when it started?
Nothing.
Nothing, like just chilling?
Yep.
Okay. Well, does she have any associated pain?
None.
Any new medications?
She is on the last 4 weeks of her steroid from a gastric bypass procedure.
Interesting. And she didn't have any complications post-surgically?
Nope.
Any lumbar pain?
None.
Any signs of systemic illness?
Be more specific.
Like, is she having any vitals changes, any fever?
None of that.
Any swelling?
No.
Any redness?
Nope.
Any loss of sensation?
She has some impaired sensation, yes.
Where?
Down the leg.
The whole leg?
The whole leg.
The whole leg? Like from stem to stern, the whole leg.
Mm-hmm.
Is it impaired light touch?
Yes. But
Any,
not absent.
Not absent. Okay.
Not absent.
So she can feel it. It just doesn't feel normal.
Right.
Okay. And then were you able to access the post-op notes?
For the gastric bypass?
Mm-hmm.
I probably could have. I didn't, but I could have.
Okay. So you don't know if there was any history, any like post-surgical or any incident that happened in surgery?
No.
I just had a patient recently who had a sacral plexus injury during an abdominal procedure, which is why I asked.
Oh, okay. Nope, this
Any,
is all new onset.
Any other upper motor neuron signs?
She has a 1-beat clonus.
Just one.
Just one.
And how were her reflexes?
I didn't test them.
You didn't tell.
I know. I was young. I was young, I admit it.
Yeah, I actually said to somebody the other day, I test patellar reflexes just for kicks.
Quite literally.
And the person was like, no, well, I do it like this and I hold my hand here and I see that. I was like, no, you missed the point. Let me see. How is her functional mobility?
She has profound weakness the entire length of the leg, and she's ataxic.
Is it worse proximal or distal?
She's more distally weak than proximally.
And is she able to ambulate independently?
With a walker, but it does not look good.
And does she feel like the symptoms are progressing rapidly?
So it all showed up, she said, in the last 24 hours before arriving in the ED.
And has it like gotten worse over that time period?
Not that I remember.
So any upper extremity issues?
None.
And any like abnormal central findings on like oculomotor exam?
None.
So I don't know. And the symptoms are not changeable or reproducible?
They are. So she is profoundly weak
Mhm.
on one leg with an obvious foot drop, but it's the whole leg.
But
not
no
just-
mechanical changes like repeated movements or anything like that.
Mm-mm.
So I feel like in this particular, she has any recent vaccinations?
Nope.
I would probably send her for imaging.
Which one?
I would probably start with the CT,
Of?
her brain, because I feel like there's something unusual happening here. And
Totally.
okay, one more question. Any unusual substances like drugs or alcohol?
Nope. Just the steroid postoperatively.
Any exposures to chemical substances?
Nope. None
No
that she admitted to.
gasoline coverage? Yeah, I would probably refer her back to the medical team for a workup of central findings in this case, because it doesn't really sound very peripheral to me. And it bothers me that it's rapid onset, that she's so young, that she recently had surgery, and that she has some central findings.
Totally agree. So she had only had lumbar x-rays done
Mhm.
before I got there, and they said, this is non-surgical. We need you to give her an AFO and discharge.
Mm,
After my exam, no one else had seen the clonus, and it was asymmetrical, which is why the one beat was important.
right.
So clonus plus global weakness plus ataxia, and now we have neurologic.
Yeah.
So we did, and I recommended she go back for imaging. And I said, this may not be neurosurgical at the lumbar spine, but it's absolutely neurologic.
Right.
And we need to look at her head. So she was admitted under observation, got the CT of her head, and they found a new plaque for MS.
Ew, boo for the patient.
But her mom was a PT, and PT found it, so I felt very validated.
Hooray for PT, but
I
boo for
know.
this poor patient.
I know, yeah, but they
So-
wanted me to send her out from fully independent 24 hours ago to terribly walking sort of in a walker with a full new onset neurologic injury. Like,
Yeah, and I think that our assessment of functional mobility specifically is something that sets us apart. I've had some neurologists ask, can you as a physical therapist round with us? Because your ability to help the patient mobilize will tell us so much. And I think that'd be a great way to do things. But I think in most cases, it's probably not yet feasible, but I would like to see more models go that way.
I'm totally on board. I'm going to start rounding with our ED physicians during handoff.
I love that. I definitely have too many to do that, but I think that's a great idea.
I'm going to start with the adult.
Yeah, I mean, we just have 100 beds, so we have so many different zones and physicians, and
It's like a checklist. You know?
they all hand off at the same time. So yeah, that's a great idea. It's a great idea. All right, Megan, I so much appreciate you being with us today. It was amazing to hear all the good work that you're doing to help push our profession forward, both in Colorado and across the country. So thank you so much. Any last thoughts from you?
Don't forget the policy stuff. Like, if you are not a
Mhm.
chaos junkie and you don't want to get down and dirty, that's cool. Let's just change the processes for the rest of us, though. So advocate for your skills, and you don't necessarily have to function out there, but you can certainly help us in the back end.
Love it. Thanks, Megan. Have a great day.